ahead and get started. I'm very happy to have Danny here. So those of you, I know a lot of you have met Danny already. Those of you that haven't will. So not only does Danny do the coordinator position for the internship, but also works for WIC and is currently pursuing getting the pediatric certification.
Yeah, certified specialist in pediatric nutrition. Yes. So thank you all for coming today. Welcome. Thank you for the warm introduction, Dr. Trone. My name is Danny. I'm a registered dietitian at the Florida Department of Health Women, Infants, and Children's Program, better known as WIC. And so just a quick disclosure, everything I say here during this presentation is not representative of the state of Florida and is not representative of WIC at all. So what you need to know for this presentation is that this is based on the assessment, right? So we're not going to be doing a lot of the diagnosis. We're not going to be doing a lot of the intervention or the monitoring or the evaluation. We're mainly going to be focused on the assessment because if we really nail this assessment and we have a strong assessment, it's going to make some of those other parts of the ADIME process a lot simpler to do. Something else you need to know is that if you see a bold font, that's a key takeaway. You're going to want to write it down. If it's not bold, if it's a table or a question, that's okay. That's just for you to be engaged and for your reference later on. So there's a lot to cover in this presentation. I'm not going to get through all of it today. We're mainly just going to do growth today, and then we'll do nutrition on Tuesday. But who are our peds? Who are they? Who are we helping? So, of course, we got children, 1 to 18 years old, infants, 0 to 1 year old, and then neonates, 0 days to 28 days, and gestational age. And we'll talk about what that means later on. But I just want you to imagine for a moment you're in a playground. You're in a playground, it's sunny, you're 7 years old, maybe there's a kid, he's got fair skin, thin, brown hair, and there's something that's different about this kid compared to all the other kids that are playing in the playground. And you can tell because he's got rolls of fat on his arms, on his legs, there's fat covering his eyes. And so when he goes to the slide to play with the other kids, they say something really mean. And we'll get into what exactly they say. But what I want you to know is that pediatrics, as a dietitian, we're not just helping with, lab values, right? This is a critical, irreversible stage of development. And so if nutrition is compromised in any way, that's going to set them up for failures a lot later in life. So as a pediatric dietitian, there's a lot of, compounded returns on your efforts. So if we can really optimize their nutrition with their parents in this critical stage of development, we're going to avoid a lot of problems. Like when the kid is at the slide and then the other kids say, "No, you can't get on. You're too fat. It's going to break." And so this is just one small example of the opportunities that may be denied to someone as they get older and are living in a larger body, or a smaller one, or someone with a recessed jaw. And we'll talk a lot about these things. But now you're in a hospital, right? From the playground to the hospital. You're seeing a 9-month-old infant girl. She's born prematurely at 32 weeks, and she's presenting to you with failure to thrive. She's got a history of congenital heart disease, and she's requiring surgical repair at just 6 months. And since the surgery, the parents report increasing oral aversion, difficulty feeding, and the infant is currently consuming 50% of the age-appropriate volume of a standard infant formula. Which of the following is the most appropriate initial step in the nutritional assessment of the infant? Is it going to be A, conduct a detailed dietary assessment? Is it going to be B, order a comprehensive biochemical assessment? Is it going to be C, obtain a comprehensive anthropometric assessment? Or is it going to be D, initiate continuous enteral nutrition via NG tube? Can I get a raise of hands if you think it's D? All right, raise of hand for C. Okay. What about B? C and B. What about A? Okay, so we're seeing A, C. Let's go through this, right? So first thing, what we want to look at for this question in Sinclair, this is from the Certified Pediatric Specialty Exam, nutritional assessment. So which one of these is not an assessment? I think you all know. Nobody raised their hand for D. That's not an assessment, that's an intervention. So next thing I want to point you to is failure to thrive. If you've heard failure to thrive is, less than 5th percentile for weight for age. So we already have a good idea of the anthropometrics, and we want to know the underlying cause. So it's not going to be C. So that leaves us with B and A. So next thing I want to point you to is 50% of the age-appropriate volume. We know maybe their labs are going to be messed up, being this undernourished. So this is going to be helpful, but it's not going to give us the next step. It's not going to tell us what we want to know, which is what's going on with this increased oral aversion and difficulty feeding? What's going on with the tolerance of the standard infant formula? So we want to conduct that detailed dietary assessment. That's going to guide our next steps. But before we get to the dietary assessment on Tuesday, we want to do the anthropometric assessment first. We want to know all about that stuff. So we're going to go through the age and adjustments. We're going to go through the anthropometrics themselves, growth charts, interpretations and classifications of this growth charts. And then on Tuesday, then we'll do the nutrition assessment, and we'll talk about the special cases, so trisomy 21, cerebral palsy, et cetera, et cetera. So, pediatric growth. What is growth, and how do we assess it? So growth, put simply, is the increase in size that occurs as a healthy newborn becomes an adult. Very simple. And growth is categorized pretty much in 3 different ways. We got length. So what you need to know is this. After 2 years, length becomes height. Little fun fact. Why we measure them laying down, of course they can't stand, but because the gravity hasn't had so much time to act on their spine, it's going to be 0.7 to 1 centimeter larger than height. So just something to know. And then weight, the measure of all the mass of the body tissues, right? So after 2 years of age, weight is still measured, but we want to use BMI. We want to use that proportional measurement, so weight and length, times the factor. And then also the velocity of growth can tell us a lot just by looking at how quick or how slow an infant may be growing. So, what genetics they may be predisposed to, whether or not they're at risk for obesity, if they're under stress or malnutrition. And then head circumference. Head circumference also grows over time. So how do we assess this pediatric growth? Well, it's a 5-step process. I don't know why it looks like that. But step 1 is we're going to calculate the age. Because how can we even know, where they're at on any growth chart if we don't know how old they really are? And the rest, we'll discuss as we go through it. So step 1, we're going to calculate the age. So she's born prematurely at 32 weeks. We want to calculate her adjusted gestational age. Now, just before we get to that, I want to show you this chart. This is just for you to know, in case you have, you don't need to do all the specifics, but you just need to know the rounding. So like 16 to 31 days, just round it up to a month. And we're adjusting gestational age until they turn 36 months. So full term, 39 weeks to 40 weeks and 6 days. That's a full term, full term in the stomach cooking. That's how long it's going to take, right? But you also have early term, preterm, and late preterm, and this is how they're categorized. But you also have late term and post-term, which comes with their own set of risks too. So the gestational age is the age at birth. So we know she was 32 weeks. That's her gestational age. Her chronological age is her age after birth. We know that she's seeing us at 9 months, right? That's her chronological age. So the prematurity adjustment is going to be 40 weeks. We're using right here in the middle of full term, 40 weeks minus her gestational age. So 40 weeks minus 32 weeks. So her chronological age is going to be, 9 months minus that prematurity adjustment. So let's go through it together. What's the infant's gestational age?
32 weeks.
32 weeks. Boom, right there. Good work. What's her chronological age?
9 months.
9 months. Let's go. Now, what's the prematurity adjustment? So remember, full term is 40 weeks. 8 weeks. Great work, bang. So 8 weeks or 2 months, right? So we have the prematurity adjustment. We have the chronological age. So what's their adjusted gestational age? 7 months, bang, good work. So 9 months minus 2 months is going to give us her adjusted gestational age of 7 months. So now we can appropriately plot her age on a growth chart. And here's that formula for you once again. And these are just some risks that can occur with such a, early pregnancy. So for the mom, having your infant go straight into basically an alien chamber is quite stressful and traumatic. You're missing that quality bonding time really early, in their development. So it can lead to things like postpartum depression, PTSD, anxiety. But for the baby, their lungs are just not developed. The lungs are one of the last things to develop for an infant, so they're going to be under a lot of respiratory stress. That increased work of breathing is going to lead to increased energy needs for the infant. And we're seeing a lot of hyper, a lot of problems. But also, when they're, late term or post term, they're cooking way too long, they're getting way too big. We're going to see birth injuries for the mom. The amniotic fluid is going to dry up. They're going to have dry skin. They could even choke on their, first poop, which is, instant death basically. So we just assessed their age, right? Boom. We're going to calculate their age. Now what's next? We're going to measure them. How do we measure our ped? So what is anthropometry? You probably already know this. This is the non-invasive measurements of the human body. Anthro meaning human, metro meaning to measure, anthropometry. So weight and length, right? For weight, we want to measure this at every age. The more data points we have on these anthropometrics, the better. And what's really important when measuring weight, we want to ensure that their body is, within the scale, right? And we want to make sure the scale is calibrated. These things can certainly mess you up, but number one thing that could mess the weight up is the diaper. The diaper's got to be clean. The diaper's got to be empty, because that could be a lot of weight that's added that could mess up, their plot. And then for the length, you can see here, their legs are like frogs, right? Super malleable, always bending. So we want to make sure we grab their knees and their legs, and we smash it down into the length board so we can get an accurate length. This is okay. If you have some help, it's very useful to get some help here. And we're measuring this until year 2. So head circumference, right? Use a non-stretchable tape measure here, and we're going to measure that until year 3. And it's about 34 to 35 centimeters for newborns. And this is what babies' heads could look like if they're not fully developed. It'll be quite obvious. And if they're born vaginally, you could expect some misshapenness depending on how they exit. But because the head grows rather quickly, we can see, return to normalcy pretty quickly as it grows 1.25 to 3 centimeters in that first month. And this is going to be about the size of a non-GMO cantaloupe, right? Not one of those massive cantaloupes, just a, regular small cantaloupe is about the size of this baby's head by year 2. So what are some problems that we may face in obtaining accurate measurements, right? We've talked a lot about accuracy already. What are some additional problems? Well, it's mainly going to be, issues with the limbs, right? Contractures, they can't really stand or lay down very well. Maybe they're wearing some adaptive equipment that's going to prevent you from doing these things. So what's the solution? Well, we can use arm span. So arm span is 1-to-1 pretty much until adolescence, from middle finger to middle finger is going to be 1-to-1 with their height. So we can use arm span if we see any of these problems. Some additional measurements that we can take is the mid-upper arm circumference, right? That's going to tell us about malnutrition because of the fat and the muscle here. And if we're seeing less than 110 millimeters, it's a high risk of death. There's very little fat, very little muscle on them. It's a good indicator for that. And we want to use the non-stretchable tape measure just like we use for the head. You can use the tricep skin fold. Maybe you've done this before on yourself or on an athlete or something like that. What's important for the skin fold test is that you just do the 3 measures for 3 seconds, then you take the average. And that's going to be, right here between the shoulder and the elbow. And then we can take the mid-upper arm circumference and minus it by pi, right? The circumference of a circle, ratio 3.14 times the skin fold. And that's going to give us a good indicator of their muscle mass, their total muscle mass. So boom, we measured them, right? So step 3, we're going to plot their age and their measurements now on a growth chart. So growth charts help separate normal patterns to abnormal ones. We want to see a normal, consistent growth, and unless they're severely above or below average, what we want to see is the consistency. That consistency is going to help reassure the parent that they are indeed growing in the way that they should for their genetics or their feeding. But which growth chart do we use? There's a couple of them. So if they're less than 2 years old, we want to use the WHO growth charts, the World Health Organization growth charts. And this is based on, data from 6 different countries on exclusively breastfed infants. And below the 2nd and above the 98th percentiles are going to indicate that of normal growth. So they're going to be pretty much off the growth chart at that point. If they're 2 to 20 years old, we want to use the CDC growth charts, the Center for Disease Controls, and these are based on those NHANES surveys. You may have learned in community nutrition, the national surveys that take a bunch of data from intake and growth. And so these are based on that. And below the 5th and above the 95th percentiles are going to indicate abnormal growth for this growth chart here. What about our preterms, right? What about our special cases? We use the Fenton growth charts. Now this is from a professor in the University of Calgary that has been doing a lot of research on the preterm infants for many years and was recently updated actually late last year. And this growth chart is based on the typical intrauterine growth, right? So we don't want to compare them to a growth of an infant once they're already out. We want to compare them to the growth of an infant as they would normally grow inside, in utero. You also have different growth charts for, special diseases and cases like trisomy 21, and you can use the Down syndrome chart for this. But what's important to note is that because not many of these infants exist, right, the population size is going to be really small. So it may not present a fully accurate picture, so you want to use these special growth charts in combination with either the WHO or the CDC growth chart. Yeah?
When was the last time that they did the survey? Do they update it? Or?
I don't know. There are many different ones for different diseases, and I'm not sure how they update those. For both of these, though, Z-scores, it's going to be -2 or +2, and that's going to indicate abnormal growth on all growth charts. And that's the standard deviation from the mean. So if they're 2 standard deviations above the mean, that's abnormal growth, or 2 standard deviations below the mean, that's also abnormal growth. So this is what it can look like, right? This is a WHO growth chart for someone less than 2 years old, and it's based on percentiles. So this is weight for age. So we're measuring weight as they get older, right? So it's useful to determine the velocity, how quickly they're growing for their age, or if they're trending underweight. So what can we see about this? Are they growing normally, or are they growing too slowly or too quickly? They're growing pretty quickly. What about this one? How are they trending? They're trending consistently, but underweight. So what are percentiles actually? What you need to know is that percentiles are not grades. So, when we take a test, we get 100%, that's good, right? Percentiles are not that way. Percentiles are not grades. Percentiles are useful tools for comparison and general trends. So basically, if I took all of you here in the class and I lined you up in a line from smallest to largest, the middle person is going to be the 50th percentile. So you take 100 little kids and you measure them from smallest to largest, that person in the middle is going to be the 50th person, all the way at the end is going to be at the 100th. So the 50th percentile can also measure ideal body weight. If we need to know an infant's ideal body weight, we can use the 50th percentile to find out what that may be. And they're always positive, right? At the end of the line, there's not going to be someone that's, going beneath the floor. There's no negative percentile. They'll just be, 0.01. So because of that, though, they're not really useful for determining the severity of how low someone may be or how high someone may be on a growth chart. So it's not really useful to say, this infant is really, really beneath the second percentile or giga low beneath the second percentile. These are subjective terms. And in clinical practice, we want to be objective. We want to use actual measurements. So that's when those z-scores are going to come in handy, those standard deviations. So here's some more growth charts. This is the length for age. And this is helpful to determine if they're stunting. So we can see here, it's clear cut. They're not really growing. Their height is kind of stable at the same age, and it's becoming a problem. So weight for length. This is the proportional measurement that we use before they turn 2 years old. And that's going to help us to see if they're at risk for wasting or overweight or obesity. And then once they turn up to 20 years old, we're going to be using those CDC growth charts, and we're going to be using the BMI for age. And same thing as the weight for length, helpful to determine wasting or at risk for overweight or obesity. So z-scores. Like I mentioned, z-scores are the standard deviation away from the mean, or the 50th percentile. So, like I said, they're useful for seeing the precise severity of how low or how high someone may be on a growth chart, how far above that 98th or below the second percentile. So, like I said, like saying z-score of minus 3.2 versus minus 3.6 is a lot more useful than very below or very, very below. But they're not really useful for determining trends or the velocity of weight gain or loss. If we have multiple data points, we want to use the percentiles. So here's some examples of growth charts using z-score. So here we can see, are they underweight or are they severely underweight? Right? Are they minus 2 or are they minus 3.6? Same thing for length for age. And then same thing for weight for length here as well. So are they moderate or severely malnourished, or are they overweight, or are they obese? Right, we want to use Z-scores for that. So like I said, for the Fenton growth charts, this is what they look like. We have all of the measurements on one growth chart, the length, the head circumference, and the weight. And you can see here, this is a lot steeper. It's a lot steeper because intrauterine growth is going to be a lot different than growth outside, once they exit. And we're going to be using these until 50 weeks. So once they turn 50 weeks, we can transfer them to the WHO growth chart. Does that make sense? Some indicators of malnutrition that you could use, using the Fenton is how many days to regain their birth weight, because initially, after they pass their first stool, they're going to be a little bit lower on weight. The velocity, the decline in weight or the decline in length. There's going to be some important indicators for you. So which growth chart to use? If we have 2 or more measurements, which ones do we want to use? Do we want to use percentile or Z-score? Percentile. Right, we want to use percentiles because that's going to tell us the trends. And if we have only one measurement, of course, we want to use the Z-score. So that's going to tell us the severity. And this is just a summary of all of what we just discussed. So now, we got a 12-month-old infant girl. She's born full term at 39 weeks. And you walk into the clinic, and the first thing you're asked, is my baby girl obese? Is she obese? This is a real case, right? So she's questioning, is her daughter obese? So we're going to find out. But first, what's the best growth chart to use for this assessment? Is it the WHO growth chart, length for age? Is it the CDC growth chart, BMI for age? Is it the WHO growth chart, weight for length? Or is it the WHO growth chart, weight for age? So raise your hand if you think it's A. Okay. What about B? C?
Arguing that she's obese.
She wants to know if she's obese.
Then B.
Then B?
That's not my guess.
What about C? Anyone with C? Okay, C. What about D? So let's go through it like we did the first one. So first thing, we see 12 months. So if they're 12 months, we're not going to use the CDC because that's from 2 years to 20 years. So we know she's less than 2. We want to use a WHO growth chart. So we're going to cancel that one out. We want to know if she's obese. Length for age, that's not a measure of weight. Nobody said that. Everyone knows. So now, what is it? Weight for length or weight for age? So obesity, that's a proportional measurement. So we want to use weight for length. Does that make sense? Cool. So we got her measures, right? These are her measures. Let's plot it on a growth chart. Now I need a volunteer. Who wants to come up here and plot these measurements? You got 3 seconds before I call on one of you. You don't be shy. Come up here, Noah. So, here, I want you to use this mouse here.
The mouse?
Yeah, there are 4 dots, and you can just click it and
Yep,
go like
yep.
that. So what you want to do when you get your weight and your length, first, you want to look at the length. So we see here 48.3 centimeters.
I'm gonna guess that
So
this
where is
goes
it at?
somewhere along, right?
So we see 45 at the
Here.
bottom, then we see 50,
Mm-hmm.
and they're in increments of 1.
So 3 would be right here.
Boom. Yeah, there you go. So you could just drag it down there.
Oh, I see.
You can click that to drag it, and then boom. So right there, nice, nice. And so
Thank you.
next, you got 53.3 centimeters. So you want to look at the length. And then the weight in kilograms, 4.3, okay. Boom, good work.
Thank you.
Nice.
Thank you.
Okay, so now she's a year old here. She's 76.2, 11.1. All right. Nice. Good work, Noah. So does anyone disagree with this assessment here?
I think so.
Would anyone do anything differently? Okay. So let's see how Noah did. Boom. Pretty much spot on. Good work, Noah. Good work. So this is what, I plotted, right? Does anyone have any, questions about this? How to plot on a growth chart? It's pretty self-explanatory, right? We take the x-axis, we take the y-axis. So boom, this is a z-score table. So I don't know how they got all these numbers. It's been a while since I had, statistics or whatever. But what we want to do is kind of same thing here. Look at the length. We see 76.2. So go down here. Closest thing is 76. And then we go all the way down to 11.1 kilograms. These are kilograms. And then the closest thing is 11.2. So not really exact. It's not really exact, but it's telling us, oh, maybe close to 2 standard deviations above the mean. So this is what that would look like. But if you actually had, put it in the proper tools to get the exact z-score, you would get 1.88. Now, is that normal? Is that abnormal? Okay. So we just plotted the age and the measures on the growth chart. Good job, everyone. Now we're going to interpret this. We're going to interpret our findings. So is she obese? That's what we want to know, right? Is she obese? So before we get to that, what you need to know is about birth and birth weight classifications. So was she born? Was she born obese even? So let's go back here. Let's take a look at her first measurement. What was it? Day 1. She's about at the 50th percentile there. 19 inches, 6 pounds, 11 ounces. So let's see how she was born. So if she was beneath the 10th percentile, she would be small for gestational age. If she was between the 10th and the 90th, she would be appropriate for gestational age. If she was above the 90th, she would be large for gestational age. So she was born appropriate for gestational age, but she was climbing that growth chart pretty quickly. So in absolute terms, right, just based on her weight, low birth weight, less than 5.5 pounds. She was around 6 pounds, so not really low birth weight. Very low birth weight, 3.3 pounds. Extremely low birth weight, 2.2 pounds. So in general terms, interpreting these percentiles here, once again, remember, for the WHO growth charts, it's below the 2nd and above the 98th percentile. And for the CDC, it's below the 5th and above the 95th. And then for both of them, -2 or +2 are going to indicate that abnormal growth. So if we look here, this is a nice little table for interpreting these z-scores. We see +2, overweight, +3 is obese. And then here's another table for you to use for your interpretation. So between the 2.3 or the 2nd and the 98th percentile for the WHO, and then for the CDC, 16 to 84. So what is your initial assessment, right? Is she obese? Is she overweight? Is she normal weight? Or does she have a condition maybe causing rapid growth? So raise your hand if you think it's D. Raise your hand if you think it's C. Okay. What about B? Okay. And A? Obese? So no one thinks she's obese. Some of us think she's overweight. Some of us think she's normal weight. She's normal weight. Because remember, she was 1.88 on the Z-score. So that's in our normal range. But she was close to that 98th percentile there on the growth chart. Wasn't really sure. But she's normal weight. So why? Well, this is a screenshot from WIC. This is the ancient but very charming electronic health record that we use, Florida-wise, and they give us the exact numbers, right? So we see that her weight for height is 96.69, 97th. So can anyone tell me what the ranges are for abnormal growth on a WHO growth chart? Above 98. So this is what it actually looks like. She's normal weight. But there's an asterisk here, right? Her mother is clearly concerned about her weight. Do we just tell her that she's just normal weight and leave it at that? What else do we want to comment on this growth chart? Tall. What else?
She seems to be healthy. Just show the chart and say she's in the range.
What about the rate? Right. We're seeing consistent growth, but we're not seeing consistent growth along a couple percentiles. She's climbing really rapidly. So we want to explain to her a little bit about the velocity of growth. We want to ask questions about that. We want to ask questions about how is she feeding? Is she being overfed? How much formula is she getting? How much solid foods is she getting? Are there things in the bottle? And turns out, yes.
Just quickly, was the mom obese? Are you getting to that?
Yes.
Okay.
Yeah, I mean, from a visual assessment, that's usually how it goes, right? The kids will follow the parents. So honestly, in pediatrics, you're really dealing mainly with the parents and their habits to be a good role model for their kiddos as they grow up. So turns out, upon questioning, we're seeing that she's putting baby cereal in all of the bottles. So that's not, we don't want anything other than formula or water or whatever in the bottle. But when you start adding those extra calories, you see here that we're getting, really high weight gain velocity. You also want to remember that this WHO growth chart is based on breastfed infants, right? Not formula-fed infants. So just keep in mind that nuance there. Formula-fed infants may exhibit a little bit different growth depending on how much they're being fed. Are they being fed on a schedule, or are they being fed according to their cues? And we have more into that on Tuesday's lecture about nutrition. But the takeaway here, of course, is there's some nuance, right? It's not just, normal weight or overweight, but also that the accuracy of these measurements are essential. Because even though now we know how to plot things on a growth chart, we want those exact numbers to give those, appropriate assessments. So this is a tool that you can use in your practice. If you're in clinical peds especially, you'll probably be using this, pdtools.org. So when to be alerted, right? If we're seeing crossing multiple lines, whether down or up, that's something to notice. That's something to be alerted about. If we're seeing sharp inclines or declines, that's something we also want to be alerted. We want to note. And if we're seeing flat, we definitely want to take note of that too. So basically, the takeaway is when the pattern of consistent growth is broken. So if we no longer see consistent growth in any way along a couple percentiles, we want to take note of that. We want to ask more questions about that. So acceleration across percentiles, what we saw when catch-up growth is not desired, can be suggestive of overnutrition, right? We find out she's putting cereal in the bottle, she's definitely overfeeding. If we're seeing deceleration across multiple percentiles when not overweight, that could be poor growth. So what is catch-up growth? Catch-up growth, if they're premature, if they've had some sort of illness or sickness, we want to see a bounce back. We want to see them catch up to where they should be originally, or catch down if they're overweight. So I wouldn't be too concerned if we saw her a little bit flatten out, go towards the lower of the upper bounds of those percentiles, kind of catch down and catch one of those lower percentiles and keep climbing consistently that way. But context is important here. Let's say we see a sharp decline. What could that be indicative of? If we see a sharp decline? Sick? Yeah, exactly. Could be some sort of illness. And so if there's an illness and we see a rapid decline, for however quick the decline was, in the ideal scenario, the incline would be just as steep. That's going to show that the infant is resilient. That's going to show that it was really just illness. And during that illness, they didn't develop any aversions to eating. So if we're seeing an illness and then we see them kind of stay and level out, that could tell us, hey, maybe they didn't fully recover. Maybe they're still on some medications that are affecting their tolerance or their appetite. So failure to thrive. Remember our first baby that was preterm, that was failure to thrive. Pediatricians use this a lot, but we don't really use it because there's not really a consensus definition, but kind of the main definition that is used is just weight for age under the 5th percentile. And that's just like a easy way the pediatricians use, all right, this baby is failing to thrive. And the most common cause of this, of course, is the inadequate caloric intake, some sort of absorption issues, or increased nutrient needs. These are some other forms of malnutrition. So we also don't really use these as much. We use kind of like a sliding scale of malnutrition, but what you need to know for kwashiorkor is that they're getting sufficient energy intake, but they're not getting sufficient protein intake. So this can develop, acutely with an infection, and how we treat that is, of course, we just give them balanced macronutrients. We give them the protein that they need. Whereas marasmus is going to be more like close to starvation. So we're seeing insufficient protein and energy intake, not just protein intake. And this is going to develop, over some weeks or months. And of course, they're going to require all the macros, right? But what's important for marasmus is that they're at risk for refeeding syndrome. So while they require, all of the energy, all of the protein, we don't want to feed them too quickly because they could die. So we want to, taper up to their appropriate needs. And these are some, signs that a child or infant may have kwashiorkor or marasmus. So that enlarged fatty liver, right? If they're not getting protein, they're probably getting more fat and carbohydrates, and they're getting more than enough energy or less, so that's going to go to the liver. Could see edema, sparse hair, flaky, pasty skin, whereas this guy, he looks more like an old man, right? He's got the dry skin, no fatty liver really, and then just from their signs like lethargic versus alert and irritable, right? But this is what we typically use in the clinical setting, right? We use this sliding scale of malnutrition, so from mild to moderate and severe. And once again, we see if we only have one data point available, we want to use the z-scores, right? And this is the interpretation of those z-scores for malnutrition. And if we have 2 or more measurements available, there's a couple different things we can use. We can go from velocity, right? So we can go from weight loss. We can also use z-scores here. We can also use intake. So there's a couple things we can use if we have over 2 measurements. So the more measurements you have, the more you have at your disposal. And it's acute if it's less than 3 months and chronic if it's over 3 months. So these are just some examples of some PES statements that you can refer back to. And so for malnutrition, if they're mild malnutrition, right, just minus 1 or 2 on the Z-score, we want to analyze their nutrient intake. We want to give them a high-calorie diet, maybe some oral nutrition supplements. If they're moderate malnutrition, we want to do the same thing. But if we're not seeing an improvement, that's definitely an indication to maybe consider enteral nutrition. And if they're severe, remember refeeding syndrome. We don't want to feed them too quickly, but it's likely that they'll need 100% of their needs through enteral or parenteral nutrition. So boom, we interpreted the growth chart. Any questions so far? So now the nutrition-focused physical exam. Have y'all got a chance to do an NFPE? Okay, cool. So a lot of the same things, right? Like using the orbital fat pads, the buccal fat pads. You can also, for infants and toddlers, use the buttocks. Obviously, you got to get a consent, right? But kind of same thing here. I have this chart here for you. And then for muscle loss, same things here. And I put like from the top, going all the way down, or these are the things that you can see, right? Like you can notice these things. If you're not really sure, that's when maybe you want to ask for consent. Say, hey, I would like to, check for any muscle loss or fat loss. Is it okay if I just place my hands on your toddler's face? If the toddler is old enough, of course, you ask them. Being calm, being happy, like these things are going to help. Say, eyes on me, like just make sure they keep their eyes on you so they feel safe. And, you perform the NFPE as you would an adult. So boom, we did the nutrition-focused physical exam. So the next session is in pediatric nutrition. What time are we at? All right. Well, this is, we can keep going. All right, let's keep going. Let's do pediatric nutrition. So how do we assess the nutrient needs for growth? So we got stooling, nutrient needs, milestone history. These are the ways that we can assess pediatric growth, right? Or nutrition, rather. So before infants even eat, they're going to pass their first stool. And that's called meconium. And it can be a lot. So there's not really space for them to eat until they pass their first stool. So that's why we're talking about this first. And we can learn a lot by how their stool progresses. So I want to just pass this around here right quick and show you kind of like how small an infant's stomach really is. So I have a 2D and a 3D model. You could take off the rubber bands and just pass them around. So it's very small. You can see here day one, it's basically the size of a marble, their stomach. So very, very small. And these are the colors that one can expect as they progress. So just pass that around, see for yourself. Colors. Let's talk about the colors. So that initial meconium is going to be black, dark green. It's been sitting there for so long, so it's going to be really dark. It's like tar. Doesn't actually smell too bad at all. And that's within 24 hours of birth. If that's not happening within 24 hours of birth, that's definitely concerning. Green, that's the transitional, right? 2 to 4 days, they can have some green, but if they're fed formula that has iron, that green can stick around for a lot longer. And then yellow, so if they're breastfed, typically the stool will be yellow. It'll be seedy, kind of like if you mixed Dijon mustard and cottage cheese together. That's what it looks like. Also can smell a little bit sweet if they're fully breastfed. But if they're formula fed or if they're starting solids, we see brown, we see more pasty, kind of like a thinned out peanut butter. And that's going to be a little bit more bad smelling with the formula. And these are the red flags, right? So if it's black, at any other time other than that first day, that could indicate there's some bleeding in the upper GI, right? Or if it's red, that could indicate some bleeding in the lower GI. And if it's white, that's a big issue. Their liver may not be producing any bile. So these are like immediate referrals. If we see any of these black, white, or red, those are red flags. We want to refer to the pediatrician there. Something else? Yeah.
I know, like, in the hospital, like, obviously, after the infant's born, they kind of get looked at by the doctor, and, like, but, like, when they go and, like, are handed to their mom, like, so sometimes they will latch, kind of in that, like,
Yes.
kind of time frame, but, like, so in that kind of first few hours, they still will kind of have that first kind of stool before they will latch on them.
Yeah, I mean, typically they may not be ready to feed, so they'll have to pass that stool before they can latch. That's why at a baby-friendly hospital like FSU TMH, they're giving the parents 24 hours, rooming in with their infant so they could maximize the time with their infant so we can really, help them latch after they pass this stool. So it could be a long process. Of course, that initial skin to skin is really going to set the mother and baby's bond up for success initially. So even if they haven't passed the stool, that skin to skin is really important. Also, the sharing of bacteria, really helpful for the baby's immunity over time. Does that answer your question? Something else that infant stool can tell us is, intake, inputs and outputs, right? So we could tell a lot about if they're getting enough food from how much they're actually outputting, right? So this is kind of like what you can expect. So you'll notice here like day 1, day 2, day 3, day 4, we're seeing stepwise increases in the amount of dirty diapers. So day 1, 1 dirty diaper, 2, 2, 3, 3, 4, and 4. And then we kind of level off as we go to 9 to 12 months. You can expect, 1 to 3 a day. And constipation, of course, if they're having trouble going to the bathroom, you'll notice that. If it's dry, hard, dark, clear signs of constipation, maybe they're not getting enough fluids. And diarrhea is if the stool is very watery. So if it's not pasty, it's not seedy, if it's very watery, it's thin, it's going through the diaper, that's definitely diarrhea that can indicate some sort of infection. So, bang, we talked about stooling. Now let's talk about fluid needs. So why are fluids important? What fluids are okay to provide? When can we provide them, and how do we determine how much to provide? So fluids for maintenance and fluids for growth. So for maintenance, this is just for homeostasis, right? For the functions, but for growth, these are the amount of fluids that are needed to grow, to get all the adequate energy and nutrients. So initial acceptable fluids for the first pretty much 4 to 6 months is just going to be formula or breast milk. Breast milk or formula, that's it. That's all an infant needs. And they should only drink this unless it's otherwise indicated for another reason, which we'll get into. And so no other food in the bottles, right? We don't want to put anything else in the bottle, just the food. Water. So as we know, all the baby fruits and the baby vegetables, they have fiber in them. And fiber needs water to pass through. So once they start eating some of those solid foods, that's when we can introduce some water to help that fiber pass. juice, right? Really no amount of juice is okay for a healthy infant that's not constipated, because this is just concentrated sugar. You see a lot of parents giving their infants a lot of juice, and that's definitely going to lead to super high growth velocity, some issues orally as well. But the juice, like prune juice and pear juice, has sorbitol, and those sugar alcohols can help draw water into the stool, help stimulate the gut to relieve constipation. So just like 1 to 4 ounces may be indicated if they have constipation. Milk. So both cow's milk and plant-based milk is not, we don't want to give that to an infant until they're 1 year old, just breast milk or formula, because these are just not nutritionally adequate, right? So how do we know the amounts? So generally, we really want to pay attention to baby. We want to see how baby is feeling. So some initial cues, they're opening their mouth, they're being a little bit more alert, they're looking around. Later on, some middle of the cues, maybe they're putting their hands to their mouth, their fists are going up, they're making a little bit more noises. But if they're having a full-on crash out, then it's likely the parents missed those earlier and middle hunger cues, which can lead to the baby either not feeding, making it a vicious cycle, or overfeeding. So if Guardian is only feeding when they're full on crying, then that's probably they missed those hunger cues. Or if they just fed baby and baby's still crying or still exhibiting some of these cues, maybe they just need to be held. Maybe they just need to be cuddled. So a lot of times parents will be always just giving the bottle or giving the breast at any form of discomfort to the baby. The baby never learns to self-regulate. The baby doesn't get any time with the parents. So we're seeing a lot of overfeeding and under-cuddling. So sometimes they're not actually hungry. They just want to spend some time with you. And we can use these for the first 6 months. Once about 4 to 6 months, once they start eating those solid foods, we want to get them more on a schedule to help them get ready for eating regularly. This is just, the general amounts. Yes?
How does the breastfeeding volume relate to the stomach size within the first few days?
So the amount of breast milk that's produced is very little in the initial time, because you saw, it's so little. And so a lot of times mothers are very concerned that they're not producing enough. But if baby is, latching at the breast, swallowing, you hear them swallowing, they're feeding 5 to 10 minutes. We look at the growth chart, they're growing, they have the adequate number of dirty diapers. So while the mother may be concerned about the amount of milk that she's producing, if we look at all of the bigger picture, then we can see, okay, they're probably getting enough, or maybe they're not getting enough. Does that make sense?
Yeah, so it correlates with the really small amounts in the beginning.
Yeah, so from birth to 1 month, it's 2 ounces, right? So very little, very little. And so a lot of times mothers may be concerned, so then they go to formula. But you have to remember, perhaps if you learned this in maternal nutrition, that breast milk is created on a supply and demand basis. So if you're supplying less, you're going to produce less. Does that make sense? So this is for your information. But how do we tell the specific amounts, right? The specific amounts of fluid, how can we tell that? Well, we can use the Holiday-Seeger equation. So this is going to calculate the fluid needs for enteral, parenteral nutrition formulas over a 24-hour period. And it goes something like this. For the first 10 kilos, 100 mils per kilo, 10 to 20 kilos, 1,000 mils plus 50 ml times every kilo above 10. So if they're 15 kilos, that's 50 ml times 5 plus 1,000. And then for 20 kilos, it's every kilo above 20 plus these numbers. So the specific amounts for fluid needs is the Holiday-Seeger equation. Iron. right? Maybe you've learned this already. Breast milk does not contain enough iron for infants after about 4 months. So the recommended supplementation is just 2 to 4 milligrams per kilogram. And if we remember, iron holds oxygen for the blood. So if they don't get enough iron, their blood is not appropriately oxygenated, their brain is not getting all the oxygen it needs for growth, and we can see long-term consequences in their cognition, in their memory, and their development. So iron supplementation is really important, but it's not necessary if the infant is receiving an iron fortified formula, of course. So what about energy needs? Where are we at on time? You got 15 minutes or 10 to 15 minutes? I'm going to stop here. And then we'll talk more about this on Tuesday. But any questions so far? Okay. Well, thank you all so much. Appreciate your attention.
One thing, we're going to do the quiz on Thursday. Since Danny's going to be kind enough to come back, I want to make sure we get through everything that Danny needs to get through. So, quiz moved to Thursday.
Thank you. Thank you.
Thank you.
Yeah, yeah.
Now it's time to ask questions, because this is not my area, so. That was great.
Thanks. Yes.
What do you do in the instance where, like, I guess this wouldn't be, like, infant related, I guess, but, like, when you have a parent who's kind of like a hypochondriac about everything usually, but, like, specifically about what they eat, and then they just kind of use the same mannerism of, like, oh, they're just a picky eater, like, I only want them to have this and this. Like, how do you maneuver them to, like, make sure their kid's growing at an adequate, like, for their age, but, like, because they're not getting basically the nutrients that they need because they're being held back from their parent?
Yes, that's a great question. So, unfortunately, the children will usually always grow up eating how their parents eat. So, if I can't get them to understand that based on whatever measurements, based on the appropriate needs, that they're not actually getting the nutrients that they need, and the parent is still, not wanting to change, that's a readiness for change issue, right? But I think how I would approach that is I would come from the consequences of not changing. So I would ask them how they feel about their own way of eating. Has it served them? And why has it served them? And maybe there's something there that we can work on. Maybe there's some, bad feelings about how she's actually eating or why she's eating that way. And we want to focus on the parents, because they have total power. I can't go to their house and feed their children. So at the end of the day, I want to find out more about why they're like this and what they think that would mean for their infant as they grow.
Follow-up. Is
Yeah.
there, I don't know if there's regulations or just personal opinion at a point that the child is failing to thrive and you would have to contact Children
DCF?
and Family Services?
Yeah, I've never had to do that, thankfully. So I don't actually know what that point would be, but I would assume if I see like a growth chart that's like stunting like that, and a lot of times it's the young moms, so like moms that are like 16, 18 years old, they're dealing with a lot of stuff about growing up themselves. They're not really, feeding their infant how they should. So that's when DCF is called, or they're put in a foster home, and the foster family is going to help them grow in that way. So I do speak with a lot of foster families, and usually they come from families in which the mom is like 16 years old and just not able to feed. But I haven't actually had any moment where I'm like, oh, I need to call DCF right quick. Yes?
Is the mom recommended to breastfeed, like, as long as she's producing milk?
Yeah, I mean, in some countries, they breastfeed until they're 5. So It's totally okay. You know, you could breastfeed for however long is mutually desired. Some questions I would want to know is why they may be breastfeeding for so long and why this is important to them. But I also want to make sure that they're getting the appropriate amount of solid foods. So sometimes, you know, maybe they're 2 years old, they're still breastfeeding. That's going to be okay if they're just feeding, you know, 1 to 3 times a day and they're still getting those 3 solid meals that are balanced. But if breast milk is a large component of their diet, they're going to be missing out on some of the other nutrients that are needed for growth, like iron, right? So we want to make sure they're supplementing. We want to tell them, hey, like this is why solid foods are important. They're getting all these other nutrients, phytonutrients, and things like this.
What's recommended though? Just breastfeed
Up until 1 year. Yeah, up until 1 year is recommended. But starting solids at 6 months is also really important, just to get them used to eating. The palate is most accepting when they're an infant. They're gonna take pretty much anything, typically with some consistency. So you want to make sure that you can expand their palate as much as possible to perhaps lower the likelihood of more selective eating when they turn 2 years old and develop their own preferences. Yeah.
How often do you take the measurements? Well, I know like weight and height would be like
Every year at the minimum.
but yeah, like how often would you do the other measurements like head circumference and arm circumference and things like that?
Well, it depends, like from 0 to 1. I'm not 100% sure, but I think like head circumference would be like every 3 months or every month for the first 3 months and then every 3 months going onward. But like weight and height, like as much measurements as possible is great. But then if they're also getting a lot of measurements, then that's a question like, okay, like are they sick all the time? Like why are they going to the doctor so much? So like every 3 months, I would say is a pretty good number. Okay, well, thank you all so much. Appreciate your time and attention. All right, thank you all so much for your patience. Appreciate being here. Appreciate that y'all are here. So if you remember, last time we discussed about basically all of pediatric growth, you know, in short. We talked about, you know, adjusted gestational age, how to calculate their age, how to measure them, how to put them on a growth chart, how to interpret the growth chart, and also, you know, a little bit about the nutrition-focused physical exam, which you know. Then we went into just a little bit on you know, nutrition with the fluid needs and the stooling and how that's a great, you know, indicator for if they're getting enough fluids and things. But now we're on energy and nutrient needs. So some questions that we're going to answer today is, why is this important? What are the different methods of calculating the energy and nutrient needs, and when do we use each of these methods? So that's what we're going to answer today. If we can just move on. What's going on here? It's in this like edit mode. Just press it. Oh, so.
Okay, now she won't.
Oh, yeah, okay. All right, y'all. So when you think of total daily energy expenditure, like your own energy expenditure for yourself, what are the 3 components that goes into that? Can anyone tell me? Okay, your basal energy expenditure, the B. What else? There's 2 more things. Physical activity, yes, of course. One more.
Any injury?
That'll be after. That'll be like a stress factor, which we can apply after. But what about for maintenance as an adult? No. It's got to do with food. Thermic effect of food. Yes, that's right. So
That's why I was waiting, because I pressed the thing again. I was trying to figure out the sound there.
okay, I think that works. All right. So yeah, these are the components of our energy expenditure. But now, for everyone that has tried to put on some muscle in the past, what is that called? That phase when you're trying to grow? Anabolic. Yes, I heard that somewhere. Anabolic. That's an anabolic process. And what do you need more of? More energy. That's right. You need more calories. But for our pediatric patients, they're in a constant anabolic state. So there's got an extra component of their energy needs, and that's the energy cost of growth. So their total daily energy expenditure, especially in adolescence, may even be higher than an adult at maintenance because of this energy cost of growth. And it's going to vary depending on their age and their condition. Does this make sense, y'all? Cool. So, of course, as you know from adults, the gold standard for calculating energy needs is going to be the indirect calorimetry, right? But it's very rare that you're ever going to get access to this type of machine, and it only measures, the basal energy expenditure at a certain point of time. So you got to keep redoing it. It may be the gold standard, but it's very rarely used, but you need to know that it is the gold standard. So at birth, right, we're going to start from day 0. A key nutrient at birth that's needed is vitamin K. Right? Imagine you give birth to a baby, or you have a baby. The baby has a minor fall, maybe some bruising, some internal bleeding, and they die. Because there's not enough vitamin K for clotting. They have poor status at birth. Their gut microbiota is not, fully flourishing yet, so decreased synthesis, and it's a little bit low concentration in human milk without any fortifiers. So how do we prevent this? Very easy. A nutrient we all know and love, vitamin K, 1 milligram injected intramuscularly, usually in the foot. And that's going to reduce the inherent risk of bleeding during this newborn period. So really important, vitamin K at birth. Some other nutrients. So you don't need to know all of these, right? But I put it here for your information. What you do need to know is that most U.S. states encourage this screening panel, the recommended uniform screening panel. And it's going to screen for 40 different rare disorders that do, have nutrient complications. So for instance, thank you so much.
I just put that in. None of the video is working.
Thank you for your speedy
It's
response.
done right now.
Thank you. So organic acid conditions, fatty acid oxidation disorders, amino acid disorders like phenylketonuria, PKU, which we're going to discuss today, hypothyroidism, sickle cell anemia, cystic fibrosis, congenital heart disease, and we'll talk about CF today. So all of these disorders are screened just in a little, little blood prick, little blood panel that's done pretty much at birth, but it's not legally required, so, make sure that this is done to your infant if you plan on having children. So we went over, some of those nutrient needs, but now let's get into energy needs. So dietary reference intakes. There's a lot of components of the DRIs similar to how there are components of our energy needs. Can anyone tell me the components of the dietary reference intakes? So I'll give you a hint. The one that we all know, it's in percentages on a nutrition facts label. What is that called? Starts with the R. The RDA, yes, great job. So the RDA is one of the dietary reference intakes, and what's important to know about the RDA is that it's for 98% of healthy people. So this is like a big wide net that we cast over the population to say, hey, if you meet these numbers, 98% of you, you're going to be fine. Can anyone tell me another component of the dietary reference intakes? Upper limit? Yes, that is one. What is the upper limit?
Like what is tolerable before it gets like, what's it called? Before it gets like detrimental.
Yeah, the safe amount of a nutrient that you can intake before it gets a little dangerous. So that's one of them. Can anyone give me some more? There's some more.
You have like the adequate intake.
Yes, adequate intake. And when is that used?
I think that's for about like what for like about 50% of people that can like work.
The adequate intake is used when there's not enough evidence to set a number like 50%. But you're close on the 50th percent because we haven't hit that one yet. Which is the one for 50% of the population? The estimated average requirement, our ear's estimated nutrient requirements for 50% of healthy people. And if you remember, everything that's bolded, that's a key takeaway. You want to know the things that are bolded. So this is for 50% and this is for 98%. Then we got adequate intake, we mentioned that. Tolerable upper intake, we mentioned that. And then we also got the acceptable macronutrient distribution range. So this is the range of estimated intakes for particular macronutrient that's going to be associated with reduced chronic disease risk. These are the ones that you need to know. These are what we're going to be comparing to. So what's important to know for all of these is, unlike indirect calorimetry, which is going to be as precise as possible, these are all estimated. These are all estimated needs with a formula. Without the gaseous exchanges, we're not going to get close to that precise number. These are all estimated. So comparing the estimated, average requirement to the RDAs, why would which one do we want to use when we're calculating needs for a pediatric population? Which one of these do we want to use? What would it depend on?
In terms of like their height, their weight, what underlying health conditions they have,
Okay.
any injuries, any metabolic conditions.
Okay. Does anyone think we should use the EARs instead? Why?
Because the RNA is for 98% of healthy populations, and I feel like pediatrics, it's like they're not fully developed to classify them as healthy adults.
Bang. Yes, exactly. That's exactly right. So like if we're doing the RDAs for our infants, we're probably going to be overfeeding a lot of them. And when we think about ideal body weight, right, at the 50th percentile, when we think about everything's about that 50th percentile for the growth, this, again, we're using the 50th percentile. We're going to stay on that theme. We want to use the EARs. So like I mentioned, the RDAs are useful as a safety net for a lot of the key micronutrients like, your B vitamins, in which it don't matter how many you're going to get, you'll pee them out, it's okay. But the EARs are useful for calculating the balanced energy needs for a growing pediatric patient. Does that make sense? Cool. So here's a quick reference guide, for your use. So we're going to go into some formulas in a minute, but you can go through the ages and the weight and the height, and then get the estimated energy need this way. This is just a quick guide. But we're going to start from largest to smallest peds, right? So we're starting with our obese peds. This is the formula for it. What I want you to notice is that this is only for 3 to 18 years. So remember what growth chart are we using for people over age 2? CDC. We're using the CDC, and what does CDC typically use? BMI for age, that's right, yes. So that's a proportional measurement. We're going to be talking about obesity there. So for this is the formula. We got age, we got weight, we got height, we got physical activity, we got all of the things for energy expenditure. And I don't really know how these numbers are exactly calculated, but of course we're putting in these numbers for the energy cost of growth. You may notice for the boys there's even a negative number here. So these are for our obese peds for the modified estimated average requirement. For our healthy peds, you may notice here first thing that these are a lot shorter, these formulas, a lot easier to do from 0 months to 35 months. Can anyone think of a reason why there's no height in these formulas here? Is length here? It's changing too consistently, too often. Negligible? Why? Because they're tiny. Does this give you a hint? Do y'all remember what this is? Arm span. Arm span grows 1-to-1 with their height. So why I'm saying that is because as they grow, it's pretty proportional. Like the weight and the height, they're going to be growing at kind of similar rates. So the weight for length, we want to see a normal curve, and we typically do see that. So we don't really need to use length or height in these formulas here. We can just use the weight because of that proportionality. So for 0 to 35 months, we're just using weight, and then boom, from 3 to 8 years, we're back using all of the things, including physical activity, which we'll discuss kind of what these numbers mean in a moment. So now for underweight peds, remember we're using ideal body weight. Ideal body weight is at the what percentile? The 50th percentile, right. So we look at their age, we plot it on the chart, we look for the 50th percentile, what's their ideal body weight, and bang, we just put it right there in kilograms up to 35 months. And then here are the formulas, same thing, literally the exact same formulas for our healthy and our underweight peds, but we're just using ideal body weight. Make sense? So here are some details about physical activity. Now, when you start to use some of these modifiers like physical activity or stress, you want to use your clinical judgment here, right? Because this is a range of numbers. So 1.0 to 1.39. So you would ask some questions about their physical activity level, but here's just a quick guide as to what those things mean. So for sedentary, you want to think of your kid that's on the tablet all the time, on Miss Rachel, on Coco Melon. They're not moving a lot. Maybe they go to the dinner table 3 times a day. They'll go to the bus for school. For your low active, maybe they're getting some playtime outside every day, but it's nothing too serious. We're not talking about sports or anything like that at this level. Maybe just some hide and seek type things for an hour. And then we got active here. This is, okay, we're going to the park every day. This is something we look forward to. We're playing around with a bunch of other kids. And then we got very active. We got our high, overachievers, athletes doing a lot of things like chase, just straight up, just all every day, some recreational activity, and they're going to be at this very active level. So now, critically ill. We're going down even further. We're at our critically ill pediatric population here. And we can use the World Health Organization equation for this. And something you may notice here is that it's also just weight-based. And a lot of times with our critically ill patients, we can't really measure them very well, but they have a bed scale. So that's okay. We can use weight, but maybe they're broken in some places, and it's not really helpful to use to get their height safely. So if you don't have their height or their length and they're critically ill, you want to use the WHO equation. Now, if you do have their length and their height, you don't want to use the WHO equation. You want to preferably use the Schofield equation, right? And these are going to have your weight, your height, and the age. So pretty much all the things for critically ill.
I was just going to add, typically on the RD exam, they're not going to ask you to know these equations. You have to know the name of them. So usually a question would be like, which of the following equations would be used for a critically ill pediatric?
And we got that question coming up. That's all good. Yeah, it's true. So like I put these here for you to give to you, as a gift. So when you go into practice and maybe you deal with your pediatric population, you'll be able to use this PowerPoint and reference it, as you would any other thing if there's not some good references there. But yes, so with our critically ill population, we may have some stress factors. And once again, you want to use your clinical judgment with determining some of these numbers, but I just gave a few of you here to you today. So for preterms, even smaller, we can use there's actually a lot for preterms. There's just a lot of formulas in general, and but this is just one for the preterms. I chose the Aspen, and this is going to be for enteral and parenteral nutrition. So they're really ill. They're not able to get their needs orally. They're having some feeding difficulties, in being so small and being in this stage with no reserves or anything. And it's just a simple, calorie per kilogram per day. And of course, you'll notice for the late preterms, we're seeing increased energy and protein needs. Why? What growth pattern do we want to get our preterms on?
You don't want them to stay in their lower percentiles.
How do we want them to grow? As if they were in what environment?
We need to catch up growth.
Yes. We would like to see catch-up growth. We would like to see them on the intrauterine growth pattern. Now, what growth chart do we use to determine that? Fenton. Yeah, that's right. Great job. So they got the increased energy needs, and we can calculate it in this way. Now, this is just another table for your reference here. Like Dr. Chone said, you don't need to know all of these things, but it's for you to know, especially with parenteral nutrition, when a lot of these minerals can get really important. Depending, it's a matter of life and death at this point. And here's a table for you to use. Now, this is basically all what we discussed in one slide in a summary. So if they're obese, we use the obesity estimated EAR. If they're healthy, just the EAR. Underweight, the IBW EAR. Critically ill, we use the WHO. Critically ill with length and height, we use the Schofield. Critically ill with stress factors, we can use either times those stress factors. And then this is 1. But once again, key words here, this is really simplified, right? When you get into practice, you're going to encounter a lot of different formulas, and likely you want to use the ones that the dietitians are using in the hospital, but it's important for you to get an understanding of, when you would use each of these and why. Does that make sense? Cool. So now we're in the hospital again. We got a 7-year-old boy. He fell 11 feet from a treehouse and hit his head. He sustained a closed head injury. He's on Glasgow Coma Scale 9 and right femur fracture. He's currently day 4 post-injury. He's hemodynamically stable, sedated, and mechanically ventilated. He weighs 25 kilos and is 125 centimeters tall. Indirect calorimetry is unavailable. So what is the best equation to estimate his energy needs? Is it going to be the Holiday-Seeger? Is it going to be our EAR? The WHO? Or the Schofield? Raise your hand if you think it's A, B, C. Damn, I just gave it to you, I guess. It's D. Yeah, y'all know it's D, right? Cool. So now, calculate it. Get out your paper, get out your pen, get out your calculator, whatever you need to do. I want you to calculate his estimated energy needs. And here's the formula. And of course, he's got some things going on. So take a look at what he's got going on. Pick a number, any number, and let me know what you get. I'll give you 2 minutes. You just walked into calculating a formula, estimated energy needs. You got 2 minutes. Let's go. That's a really cool laptop cover. One minute. Okay, 20 seconds. Five, 4, 3, 2, 1. I hope you all got it. Anyone want to share their answer? 1388. Okay. We're getting similar numbers here. Is everyone getting 1388? Okay, did I mess up? Yeah, go ahead.
I got 1,814.
1,814?
Yeah.
All right, let's go over it. So we're using the Schofield, right, for 3 to 10 years. You want to make sure you're using the Schofield for 3 to 10 years. I'm just plugging in the numbers here, right? But what's important to know, we're doing 1.3, right? 1.3. Okay, boom. All right, boom. Are these numbers looking familiar? Okay. Did everyone get this number at the end? Okay. Okay, all right. I just forgot. All right. Cool. So yeah, 1387, 0.78. So 1388, yes. What's important to note is that this last number here was their estimated, energy requirements, right? So we're seeing a 320 calorie hypermetabolic gap. Now, Dr. Chone, did you choose a number that's not 1.3?
I did not.
What number did you choose, Noah?
Choose 1.4 because he also has a leg fracture.
Nice. Yes. So boom. You want to choose, he's got a right femur fracture too. So you can choose 1.3, you could choose 1.4, that might be a bit high, 1.35, something like that. So use your clinical judgment, see how he actually is, how bad the fracture is. You need to see him, but yeah, he's got 2 things going on. So you can use 1.3, add a little bit to help with the healing process. But yes, what's your question?
I just know him being mechanically ventilated.
Okay.
To add more calories for that too.
That's a great question. I don't remember. To be real with you, I don't remember. But what I did put that, he's stable. So like if he's on like vasopressors or something like that, like the energy needs like will be different, especially like, you know, he's day 1 of injury. He's going to be a lot more unstable. So you're going to need to be doing those energy needs like, you know, on a daily basis. But as for mech ventilation, I don't remember if it's more. I don't think so. Yeah, I don't know them. Is to be real with you. But yeah, that's what I wanted to point out. So great work there, Noah. Boom, bang. We did nutrient needs, y'all. Good work. Now we're gonna do milestones. This is my favorite part of the lecture, is the milestones. So how do we actually expect infants to grow? Oops. That's not it. Okay. How do we expect them to grow? So first thing, are they ready for hospital discharge? That's the first milestone, right? How do we know if they're ready for hospital discharge? Anyone want to take a guess? How do we know if they're ready for discharge?
Wait, they have to meet the weight for a car seat.
Wait for a car seat.
Yeah.
I didn't know that. That's not up there. That's great. I like that. Anything else? What about feeding? Think about feeding. First stool? Okay. That's a good answer. Feeding? What else?
I guess like their habits if they are like taking in any feedings, either breastfeeding or bottle feeds.
Boom. Yes. Bang. Good work. So I think that's one too. But definitely, you know, wait for the car seat, especially if they're super preterm. But yeah, we want them to demonstrate the ability to breastfeed or take to the bottles, so we can, you know, happily send them on their way and know that they're going to be fed and growing. For you, you know, if you decide to have children, if you decide to breastfeed, what you need to know are there's things called baby-friendly hospitals. And FSU Health TMH is one of these, and this is an important certification that's awarded by WHO and UNICEF. And these hospitals have to meet like rigorous requirements. You know, some of them skin-to-skin contact at least an hour after birth. No central nurseries, right? You know, we don't want a big unit where all the babies are separated. Breastfeeding first, no supplements unless medically necessary. No pacifiers. No formula marketing, and staff being trained on breastfeeding. There's a couple more, but here are the main ones. But nevertheless, they should still be evaluated for supplementation. You know, maybe they need a multi, iron, vitamin D. And they, you know, if they're preterm, they may need some human milk fortifier for those increased needs. They may need some formula feeding, like once again, for those increased needs to support growth. So, feeding advancement milestones. How do we know that our infants are ready for solid baby foods? That's the question we're going to answer here. So, from birth to 4 months, the important reflexes you need to know are as if you touch their mouth, they're gonna go to you, and that's because they want the breast. They want some food, and that's the rooting reflex. The extrusion reflex is they're putting their tongue out, you know, for proper positioning for the bottle or the breast. That's the extrusion reflex, and these are going to be present from around birth to 4 months. They're also going to have this coordinated suck, swallow, breathe. That's one way we can know if an infant is feeding well at the breast or the bottle is, are they swallowing? Are they breathing? Is there a rhythm? So that's from birth to 4 months. Now, from around 4 to 7 months, that extrusion reflex should disappear, right? So when we give an infant a spoon, we don't want them to, you know, put their tongue out and push the spoon away. We want to know that that's gone. They're going to start to develop some interest in solid foods. They'll be grabbing at the guardian's plate and food. They'll be putting their hands to their mouth, kind of, you know, showing that they're ready to eat. And then also, really importantly, is they need to have independent head control when sitting. We don't want them, bobbling about, right? Because maybe they don't have the extrusion reflex, they're showing interest in solid foods, but then you put the spoon to their mouth with some baby food and they're bobbling about, it might go down the wrong tube and we're going to get some, aspiration pneumonia or something like that, which can be quite bad. So these are the 3 criteria that we look for to determine if an infant is ready for those solid baby foods. But then later, now they're going to be starting to grab at things. We don't need to feed them ourselves all the time because they're going to be, interested in self-feeding, hopefully. So they're going to be grabbing things 7 to 10 months. And then from 10 to 12 months, the teeth are coming out. They're going to be teething. It's a little painful. They're going to be able to bite a little bit more because of those teeth. And they should be able to hold the cup without help. Now, Lauda worked at WIC, and something that I disagree with, where I work with, is that, if you give the kids nuts or something like that at age 1, it'll automatically flag them at risk for choking hazards. Now, in this country, we've done a lot of marketing for soft foods. There's a lot of processing in our foods right now to make them really soft, really easy to chew for our infants. Now, when you have such soft foods constantly, you're never really developing your jaw. You're never really letting your jaw, get the muscles, the bones to be developed really strong. So honestly, if they have teeth, they're all good for some of those raw veggies, for those nuts, and just make sure they're cut up small so you can reduce that choking risk. Some things that are still, not very good are going to be those sticky foods, those spherical foods, like our grapes, our popcorn, because that's more so about the shape of the food rather than the texture of the food. It could still go down the wrong tube and then you can, choking that way. But that's a little bit of a hot take, I guess, that I have, is that we should be offering our babies, our infants with teeth, some of these harder foods to help them develop that chewing. It's super important for the jaws. So this is how we know, once again, if they're ready for solids. And this is how we know that they're ready for the cup. Now, oh my God, I'm going to crash out here today, y'all, because there's a lot of problems with not transitioning to infants to cups. So let's get into those. These problems, the problems that we face when trying to transition our infants from bottles to cups. We see a lot of emotional attachment to the bottle, right? We're always giving them the bottle every time they cry. They're associating the bottle with soothingness and sleep as well. So they're going to sleep with the bottle. We're getting cavities and things with that. And they're never taught to self-regulate without the bottle. So there's a big attachment. That's one problem. Another problem is more on the guardian side. It's just really easy to give an infant a bottle. It's very easy. Sucking is easier. How many of us have straw cups? We know it's easier. It's easier to drink out of a straw. The infant cries, give them the bottle. Never really getting time with the guardian. And of course, if they're learning to use the cup, obviously they're going to spill sometimes. That's part of learning. That's part of failing. And having them fail and being able to self-regulate through those failures is really important, but it's a little difficult, right? This is not easy stuff. It's simple, but it's not easy. So it's very convenient to continue giving the bottle. And then, of course, right when they're in this learning period, maybe the guardian is concerned, oh shoot, my infant is not getting enough, so we want to continue giving them the bottle because we know that's going to work, they're going to drink, and they won't be dehydrated, they'll get the nutrients they need. So these are the problems that are associated with transitioning from bottles to cup. Now, what are the long-term consequences of keeping with the bottle? Now, I want to tell you a story. So there's this girl, she's 1 year old, and she's having a hard time eating more solid foods. She's only eating rice, mango, tuna. Maybe that's it. 3 to 7 of her preferred foods. So her parents are really scared that she's not getting enough. So they're still giving her formula from the bottle at 1 year old. Now, cool that they would give her formula from the cup. That's fine, right? We want her to get the nutrients she needs. But they're scared that she's not going to use the cup, she'll use the bottle. Now, for the first year of her life, she's had this huge attachment to the bottle. She's not really taking to the cup well. So they give her the bottle at 1 year with some formula. 3 years old, still facing the same issues. Really selective eating. Parents are still worried, so we're still giving her the bottle. 7 years old, she's still getting the bottle. It's super attached, it's super routine, you know, right? She wakes up, she gets the bottle, and that's the bottle that she gets for the day. It's a routine now. 19 years old, we're still using the bottle because of this routine. And during this time, she's never developed the proper jaw and tongue posture to drink out of a cup. She never got that time from 9 months to 1 year. Now, there's a genetic predisposition to this, but because of this, we got a recessed jaw. We got retrognathia. So now when she goes to sleep, she's 20 years old. Now she's got a partner, and she's scared to sleep with her partner because she's snoring all the time. Bless you. She's snoring all the time. Why is she snoring? Because her jaw has no support. It has no support. It's moving back. It's pushing her tongue and her soft tissue back. Her airway is closed a little bit more, so it's making that noise. It's waking her partner up, who's a light sleeper, and her brain is never getting the oxygen it needs to feel rested because of this obstructive sleep apnea. Now, that's just that, right? But also, the bottle sucking over time, because of that posture, we might see other asymmetries, like an overbite, or perhaps a narrow palate leading to some dental malocclusions, leading to some crooked teeth, need for braces. We might even see speech impediments, right? And so let me ask you a question here, right? Who are you going to pick as the leader? Just subconsciously, we have these biases, and we look, you can tell who's more attractive. Who's going to get the swipes on Tinder? These are some hard truths that we don't really like to admit. But when you have asymmetries like this, these are lifelong issues that is prevented from going to the cup, right? Of course, these are some genetic predispositions, and there's a cure for this. This is jaw surgery, right? So these are the before and afters for jaw surgery. So it's okay. It's possible to change this, but it's quite expensive. You're putting titanium in your face to get the jaw projected out, but then you're going to be sleeping normally. You're going to feel more well rested, and you might even get opportunities that weren't presented to you beforehand. So that's why it's so important. And you will never, ever hear this in your education, by the way. This is the first and last time you'll probably ever hear this. But I want you to know that when they can grab a cup, right, and they can keep their head steady, you give them the cup, right? Because we want to avoid these issues later in life. And this is the long-term consequences, right? Short-term consequences, baby bottle tooth decay, right? You send your infant to sleep with the bottle. They got a bottle in their mouth. So we got a frequent occurrence of a highly fermentable carbohydrate, lactose, plus bacteria. That's the recipe for dental caries. And now it's a vicious cycle, right? They got these teeth. They're in pain. They're going to have softer foods all the time because they can't chew. They're not going to be eating enough. The parents are going to be scared. They're going to give them the bottle again. I see this all the time. This is the number one thing I talk about with parents, is that we need to get our infants from using bottles to using cups. And there's a lot of marketing about bottles, a lot of it. So some solutions, you can do a gradual transition, right? These are the types of bottles and cups you will see. So they're now, 6 months. We want to get them from a bottle. You can do a transition this way. You can get them a sippy cup. You can get them a straw cup. And then you can go to the 360 and the regular. And you can do this, by replacing one bottle at every meal for a week, right? And then giving them positive reinforcement every time they use that new cup, super important, until they're all replaced. And or you can commit. Just commit. They can hold the cup. If they're thirsty, they're gonna drink. Thirst is one of the most powerful motivators, and they may not take to it immediately. They may go through some strikes in which maybe you do implement, and then you go back to the gradual transition route and you go the positive reinforcement. But what's important is that we keep a steady nerve, right? The infant is crying. The infant is, yelling. It's super annoying. This is a lot easier said than done. But we have to keep a steady nerve. We have to remove the bottles and give them the cup. And then demonstrate, we can't be drinking out of straw cups ourselves and then expect our infants to be drinking out of the regular cups, right? We got to model the behavior we want to see. We got to give them positive reinforcement when they use the cup. And then if they're older, you can try the fairy bottle, the bottle fairy trade. Right? Hey, the bottle fairy's coming. No more bottle. You're going to get something in return. Maybe they need a teddy bear to sleep with because of that, the comfort. Maybe they go to the store with you. You say the bottle's no longer thing. Pick out a toy, something like this. They're graduating. Make it a special event. Make it a big thing with lots of positivity. You can try trading that way. But honestly, once they can hold their head up, hold things, I always recommend just using the 360 cup. What's a 360 cup? It's got 2 handles, so it's a lot easier to hold. And also, there's a special spout that promotes the jaw coming forward, that tongue posture of an open cup, but the spout is going to prevent spillage. So we're avoiding a lot of the inconvenience that happens with our infants not, being able to hold the cup because they haven't developed those super fine motor skills yet. So I recommend the 360 cup. Get these out of here. But yeah. Okay. I'm calm now. Cortisol down. But some solutions to preventing baby bottle tooth decay. Brushing our teeth, of course, just like us. We want to brush it twice a day with soft bristles and fluoride toothpaste. And avoiding nutrient deficiencies too. So we want to make sure they're getting a balanced diet with energy, protein, calcium, vitamin D, all the things that are going to help positive tooth formation. They're going to help, make good enamel. And yeah. Bang. We went through milestones. Yes.
How early can they brush their teeth?
When they have teeth. So when they have teeth, you can even use, there's these like little gloves with like little bristles that you can use. the toothpaste and just having them do that motion is going to be really important, and then reinforcing that. So when they do get older, they can do it themselves. That's going to be great. And then, these are lifelong habits, right? Lifelong habits, so showing them, one quadrant, 30 seconds, the other quadrant, 30 seconds, doing all of these things to making sure that they're brushing their teeth properly. Does that answer your question?
I was thinking like the wipe after, like even earlier than that, like start wiping.
Yeah, you can start wiping the gums too. Yes, you can start doing that. So we went through milestones. Any other questions? Okay, now history. This is really quick, right? We're just going to go through our A, B, C, D, E, and G. What does that mean? What does that mean? A, anthropometrics. What questions do we want to ask about anthropometrics? Any recent weight or size changes? How are they feeling about their weight and size? Look at the infant or toddler. Do a little scan, superficial NFPE here. B, biochemical. We want to ask any tests. Did you do any blood work? What about the hemoglobin level, vitamin D? Also gastric emptying time. C, clinical. Medical history, medical issues, surgeries, medications. Any medical issues that maybe you told the previous person that I should know. So a lot of times, new things will come up, or you won't know about the past because, someone didn't write the frickin' note correctly. So C for clinical, D for diet, right? Any changes in appetite or eating habits? What's a typical day of eating look like, right? We got our 24-hour recall. Are they having, are the meals at daycare? What do the meals at daycare look like? Are you packing lunch? Are they having snacks? What are the snacks? Are they using utensils yet? Are they using a cup? Are they still on formula? Are they using formula, juice? Any foods they won't eat regardless of how they're cooked, right? Food preferences, allergies, intolerances, supplements. Environment. Who decides what, where, and how much to eat? We don't want the 2-year-old making all the decisions at the table. We don't want the 2-year-old telling the parent what to make for dinner. Who decides what, where, and when, and how much to eat? Who prepares the meals? Is it someone else? Are they eating out a lot? Who is at the table? Is there even a table? Are the parents eating with them? A lot of problems stem from the parents being too busy to sit down for 15 minutes and eat in front of their children and model that positive behavior. And so the infant, the toddler, doesn't eat. And it's a big battle. Screen time. Are they on Miss Rachel at the table? Is there Coco Melon in the background? Come on. No screen time, that's a distraction. If they have too much screen time, we're seeing developmental delays. We're also seeing overeating, selective eating, because they're distracted, they're not in tune with their cues at the table. Anyone supporting appliances? Function. So, questions you always gotta ask. Constipation, diarrhea, nausea, vomiting. Any of that. What's going on there? Any excessive bloating for our infants? Are they constantly bloated? Is it hard to touch their belly all the time? Are they having any difficulty chewing or swallowing? Another question you want to ask always. Are they working with speech or occupational therapy? What are they doing there? Right? Why are they there? We want to ask these questions too. What type and how much physical activity are they getting? Right? A lot of times we'll say, oh, my kid is very active, but their screen time is 5 hours. What does that mean, really? So are they sleeping alone, on their back in a crib? Are they doing the ABCs of sleep? If they're not, we're at risk of sudden infant death syndrome. Goals, my favorite part. right? What are the goals? What's the most important thing that you want to work on in terms of improving your child's nutrition and health? What's important to you, right? Because maybe they're still using the frickin' bottle, right? And I hate it, and I hate it. But maybe that's not important to them. So I need to know what's important to them to change, because maybe it's, eating more vegetables, and I'm happy to work with them on whatever is important to them. So this is my favorite part. A lot of times we can get really focused on the problems that we see from their intake, but at the end of the day, if they don't give a damn, they're not going to change. So if they say, nothing's really important to me, then you can get into, okay, can I share my concerns with you? Here's what I see. Here's why this is concerning to me. Why? A lot of times we just get straight to the how, but we want to tell them why. Why these are concerns, why it's important to consider working on these things. And then a lot of times there are many issues, and you can ask them, what is the most realistic thing for you to tackle today with me here? What can we work on today? What's important to you of these issues to work on? So client and patient-centered, right? We want to work on that, on what's important to them. What's getting in the way of these things? What are the barriers to change, right? What's difficult? Or maybe, was there a time when you were doing well on this thing? What did your life look like at that time? Were these barriers removed? Did you have some help? How can we recreate those circumstances when they were successful? Scale of 1 to 10. So sometimes, clients will say, yeah, this is important to me. As we get through the conversation, I'm feeling a vibe that maybe they were just saying that. So I'm like, all right, I just want your honest opinion here. Like, scale of 1 to 10, how important is this to you really? Oh, 5. Okay. If we're not seeing 7 to 10, this is not really important. There's something else that we can work on. What is that? Scale of 1 to 10, how confident are you that you can do this? Right? Maybe we didn't address all those barriers. Now is a good time. Oh, a 5. Oh, why'd you give yourself a 5 and not a 7? Oh, because X, Y, Z. Here's the barriers. Just here they are on a silver platter. Okay, let's work on removing these barriers. G for goals. So A, B, C, D, E, F, and G. These are some really important questions, and it's all here for you on this one slide. Bang. We're done with the history. So, we talked about pediatric growth. We talked about stooling, nutrient needs, milestone. We got through all the questions. Now let's do the special cases, right? And these special cases require special attention that, quite frankly, I don't really know how to do. So I have not seen a lot of these cases. So I had to do some background research before this and put this together here. So trisomy 21, we know it's a presence of an extra chromosome, the 21st chromosome. So they got that, and it's in all the cells, right? All of them. And that's typically from like a random mutation during cell division and the formation of an egg or sperm. So you can use Down syndrome specific growth charts. Now, I think it was Lauda, someone had a question about the special cases growth charts and how they are measured, and I looked into that, and basically for the special case growth chart, sometimes it's less than 1,000 patients, and sometimes it's just in a specific hospital. So it tells us less about how they should grow and more about how they did grow. So that's why it could be suboptimal when using these special cases growth charts. So we want to use them in combination with either the CDC or the WHO growth charts. For our Down syndrome clients and pediatrics population, celiac actually occurs at a higher rate. So, if you're noticing, hey, like the infant is intolerant to a lot of these things with gluten, it could be that they're celiac. So if they have Down syndrome, trisomy 21, you want to recommend some screening for celiac. And they do have lower muscle tone in trisomy 21, and because it's in all the cells, right? This doesn't just affect their skeletal muscle, right? This is also affecting the muscles in the GI tract. So we can see a lot of issues with constipation because of that reduced gut motility, right? There's not those contractions in the same rate that there would be in someone without Down syndrome. So of course, soluble and insoluble fiber, the basics, and water is going to help a lot. Hypothyroidism also occurs at a higher rate. So a lot of people with Down syndrome can have a 10% lower basal metabolic rate, and that's not including the less muscle tone as well. So we're seeing a big risk of obesity and overweight with our Down syndrome peds because their energy needs are lower, and maybe we're using the RDAs, right, to calculate their needs, and it's just way too much. But because of these lower needs, it can make meeting certain nutrient needs a little bit difficult. So if they got Down syndrome, multivitamin, come on. Like, this is basic insurance here. Supplementation is very useful for our trisomy 21 peds. We don't want to use food as a reward, right? We don't want to reinforce, getting more food in tough times, because that's going to increase the rate of obesity by a lot. And of course, speech and occupational therapy is often necessary in trisomy 21. So for cerebral palsy, this is going to be abnormal brain development or damage. So it can happen at a wide range of ages, not just in early peds. And of course, there are some CP-specific growth charts. For the weight, right? They're usually sitting. They usually have some support. So we want to use wheelchair or sitting scales thank you so much, to get an accurate weight, right? We don't want to get an inaccurate weight, get inaccurate needs. Something to know about CP is that there are different subtypes of CP, right? So the dyskinetic and athenoid CP subtypes, they're constantly in motion. They got slow and languid movements, and they also have jerky movements all the time. So that adds on to their energy needs. That's a constant movement. So could be higher than 1.5 to 2 times higher than the spastic quadriplegia subtypes, where they're bound, they're pretty much paralyzed, maybe they'll do some spasms. So it could be a lot higher. So it's really important to know, what type of CP are we even talking about here? Oops, my apologies. High risk of GERD here, high risk of dehydration due to the inability to communicate. Hunger or thirst. They may constantly be drooling. They're losing fluids that way. So really high risk of dehydration. And with risk of dehydration, of course, comes risk of constipation. And because of this abnormal development, we see weak throat, jaw, and face can lead to swallowing problems, especially with all that drooling. So we definitely want to do those modified barium swallow studies, quite frequently, because we want to prevent silent aspiration, right? They could be eating food, right? But you don't know that it actually going to the wrong tube and going straight to their lungs, and they're always sick in the hospital. They have pneumonia. So high consideration for enteral nutrition for our cerebral palsy peds. And of course, because they're constantly in a chair, they're not moving against any resistance, we have a risk of osteopenia, So to help mitigate that, we want to have calcium, vitamin D, phosphorus-rich foods to help promote that essential bone growth. Of course, alongside nutrient-dense fruits and veggies, right? So some feeding concerns, right? And how do we deal with them with cerebral palsy? So for preparing food, of course, by adjusting the textures and consistency, making it a little bit easier for them to eat. They might have adaptive equipment, right? So like our forks and our spoons with handles, maybe they're a bit heavier. How can we use them? That's a lot with occupational therapy. Appropriate space between servings, right? So letting them being able to chew really well so they can swallow and not choke, and giving them ample time to do so. When to feed? So, smaller, more frequent meals throughout the day. You can see now how this is a full-time job, taking care of someone with CP here. So smaller, more frequent meals, especially help with the GERD. What to feed? So if they have trouble with asphyxiation, reflux, pneumonia, of course, we don't want to get foods that are going to exacerbate these things, or high-fat foods or spicy foods, or hard or stringy foods for the choking. Supplements, of course, supplementation is basically essential. And oral care, right? They're constantly drooling all the time. They've got their mouth open. It's going to be dry mouth. Dry mouth is super easy for bacteria to develop because it's not being washed away by those fluids. So proper oral care is really important here. Now for cystic fibrosis. So cystic fibrosis is an autosomal recessive mutation of the cystic fibrosis transmembrane conductance regulator, CFTR, which I learned for this class. And it's expressed also in pretty much every tissue of the body. So because it's expressed in every tissue of the body, it's going to lead to, basically what it does is it increases the sodium reabsorption and decreases the chloride secretion, and it's leading to this thick mucus that obstructs the lungs and ducts and tracts also throughout the GI system. So it's basically just mucus all about. And because of this, sodium reabsorption, decreased chloride secretion, it's also going to go to the skin as well. The skin is the largest organ in the body, right? So when you kiss, your pediatric population with cystic fibrosis, it's going to be a salty kiss. It's going to be a salty kiss. And we can diagnose CF, of course, with a sweat test. So because of this, this salt, this sweat, we can use a sweat test, and if it's over 60 millimoles per liter, that could be a great indication of CF. So of course, this GI obstruction and constant, dehydration through the skin can lead to the malabsorption of energy and fat-soluble vitamins and constipation. So oftentimes, what we need to do for CF, we need high fat, high sodium, fat-soluble vitamins, usually combined with some pancreatic enzyme replacement therapy, because once again, this is also affecting the pancreas. They're not secreting all the enzymes it needs to break down the fat and the nutrients to be absorbed. So seeing malabsorption issues and requiring more because of that increased breathing as well, right? So you got all this mucus. It's really difficult to breathe with all of that, and that's extra work of breathing. It's going to increase the energy needs. So for phenylketonuria, this is an infant who unfortunately did not have access to this formula. So this is the deficiency of the liver enzyme phenylalanine hydroxylase, which normally converts phenylalanine to tyrosine. We know these are amino acids in protein, right? So without this enzyme, phenylalanine accumulates to toxic levels in the body, and tyrosine becomes deficient. If untreated, causes irreversible intellectual disability. Now, very simple, right? We know that they have this because they did that screening panel, hopefully, right? In the beginning with the 40 rare disorders, this is one of them. And so we want to restrict phenylalanine in the diet by restricting natural protein. As low as 3 grams of natural protein sources. So how do they live off 3 grams of protein and not wither away? Well, probably a medical formula, right? They're going to need some formula that's modified to remove the phenylalanine. But fortunately, phenylalanine is eliminated in the diet after 24 to 72 hours, depending on the initial blood phenylalanine levels. So if they could still have some natural protein and wait for that to be.
There's 2 minutes left. I have to go. I have an emergency.
Oh, okay. Best of luck. Take care.
If you could.
This is the last 2 slides. Yeah. So we adjust this across the lifespan, based on the phenylalanine levels. Take care, Dr. Schoen. Thank you. So Rett syndrome, mutation in this gene, this can lead to seizures. So what you need to know with a lot of seizures, medication isn't really working for seizures. The ketogenic diet. Why the ketogenic diet? Because from switching the brain's energy source from glucose to ketones, this actually increases our inhibitory GABA neurotransmitters. So when you drink alcohol, these are affecting the same receptors. We're dampening these receptors, and it has a dampening effect on the brain. We're reducing excitability, which has indirect effect for seizures. What's important also to know with Rett syndrome is that puberty stops a bit early, and so reassessment for the energy needs should be done, 2 years post menarche. And if it's not done, it's going to be really difficult for them to lower their weight if they're overweight or obese because they're wheelchair bound. So we want to reassess their needs, make sure she's getting maintenance needs or the needs for growth. Lastly, spina bifida, right? I think we all know this one. Super easy to prevent, right? Folic acid. Not methylfolate, not 5-MTHF, folic acid. You want to make sure your prenatal vitamins have folic acid. With folic acid, hopefully the spine will develop, and you need to know these risks, right? Pressure sores right there, high risk of constipation due to the neuron issues in the GI, high risk of obesity due to the lower muscle mass and metabolic rate. So these are the foods we want to encourage. And then boom, these are some deficiencies associated with certain diseases or conditions. Thank you. Thank you all so much. I appreciate your time and attention. Now I have an ask. I have one final question with something to give in return. So please rate this class. Please. If you do, you will get a pocket guide to pediatric nutrition assessment. I paid for this. It's $39 worth. You'll also get the pediatric nutrition focused physical exam pocket guide, which is $13, paid for that. So please rate this class. This closes tonight. So this is your one and only chance to get these things and fill out this 3-question survey. It's just 3 questions. I would really, really appreciate if you can give me feedback on what I can do better and what you liked and what you didn't like. I would really appreciate that, and you get these in return. So that would be great. But yeah, thank you so much.
Okay, so we're going to live react, I guess, to the feedback that we got for the FSU Pediatric Growth and Nutrition class. We want to see the feedback that we got. So here we are. We're going to sign into Tally here, and let's go. It's a great, I'm not sponsored or anything, but this is just much better than Google Forms or whatever. It's taking a minute here, but I have OBS open because I'm going to see, where the feedback actually is and move my camera around accordingly. It's taking a long time here. If I had to guess, it's probably going to be about the length. It's probably going to be in this time that we're sitting here, waiting for this to log in. I think it's going to be about the length. Either the length of the class or the length of the slides. Yeah, maybe there were too many words on the slides. But my goal really was to give something away, almost like a product. Like I treated the slides like a product, because when I was in my rotations, I remember trying to look back at some of the classes, and I felt like I couldn't really get anything from the slides. So I wanted to make sure that didn't happen for this. But here we go. Let's go. Let's see it. Survey's closed. 18 submissions. 18 submissions is a great number. I think there were like probably that many people in the class. So it seems like the offer worked, which is awesome. Let's see. Okay. Let me how can you see the feedback? Okay, you can see I'm gonna make me a little bigger here. Okay, so we got a lot of good 5 stars, but a lot of 4 stars too. So let's take a look at what they mean. Let's start with all the 4 stars. Can we filter? Okay. Students' version of slides that was shorter and more concise. A lot to look at with how many there were, and don't feel like, it's the best reason. Oh my. Immediate L. Immediate. Exactly what I didn't want happened, which is ironic. This person felt like it wasn't good to look back at. So having a student's version, I never considered a student's version of the slides. Maybe that would have been interesting. Maybe I could do that in the future. Having a longer version for the presentation with all the transitions and all of that stuff. But having a student's version that just, cuts to the chase, doesn't have all the transitions and things, just the need to knows, no questions even maybe. So that's actually an interesting take. That's great feedback. That's why I did this. That's great feedback to implement in the future. But the good thing was overall informative, interesting. Enjoyed learning about the nutrient needs and the examples giving. I love that word, enjoyed. I'm glad it was enjoyable. But that's 4 stars. That's all right. For the first 5-star here, wide range of topics, quite detailed. Like the practical situations incorporated into the presentation. But if there could be a special practice as to apply the knowledge at the end, could be helpful. Interesting. Yeah, I feel like maybe the case studies were a little bit too superficial, and I could have went in a little bit more depth on one case study, or just like triple down on just one of the case studies, and like had that really complex one in the beginning, and just use that throughout. And then had another one at the end, like this person said, that could be good. But 5 stars, that's great. Interactive portions, everything was great. Okay, so that's 4 stars. Some more examples from your own experience in the field. Yeah. Yeah, I could have done that as well. Maybe the case study, like exactly like I said, like could have been about that, or just had another, like we just did one case study throughout, and then maybe another advanced case study at the end from the experience. It's okay, that's fair. How well organized it was, I love that. Easier to review the content, okay. Liked the scenario questions. Much easier to understand the concepts you were teaching. This is a 5-star. Adding a case study would be helpful. Engaging way to get people to get interested in the topic and helps ensure understanding. I also thought some of the analogies were a little unusual, but that definitely made the class more memorable. that's me. so I like the W there. I am a little unusual. And that makes sense. So 5 stars. 5 stars again. I liked how the ages were broken down. It's my favorite topic to cover. I think you did a thorough job. Okay, negative. A lot of detail on each slide. Keep it, but maybe don't have to read through it all. Yeah, that's true. The class could have been shorter if I didn't read through all the slides. I tried to say some more on top of what I read, which I think I did. Another 5-star. I enjoyed how detailed everything was, and it was interactive. I think everything was explained very well. Little hard to pay attention towards the end due to lots of information at once. That's valid. I'm gonna be real. Like I just don't really know much about those special cases, so I just kind of piled it in, and also for the sake of time as well. Okay, 4 stars. Another 4-star here. Very interactive. Enjoyed walking through problems as a class. A lot of slides and moved very quickly. Damn, I really didn't want to see quickly in this feedback, because in my last class that I taught at FSU was Intro to Nutrition, and the feedback that I got, not from a survey, but from IRL people telling me, which is way more valuable too, was that I moved too fast. So I tried to go a little slower this time. Seems like that wasn't the case for this person, but I mean, I honestly thought I did go a little slower. So maybe just a little too quick anyways. Thought there was a lot of helpful information, very interested in pediatrics, so a lot of intriguing content. There's another 4-star. Very long and a lot for one PowerPoint, okay? Maybe everything didn't need to be on the slide either. Felt like I couldn't take notes because it was all on the slide. Okay. Interesting. So, in trying to make a good product, perhaps I made a bad class. Because if everything is on the slide, literally everything that I know, and I'm reading the slide, and then people can't take notes. And I noticed that in the class. I was like, no one is taking notes. But when I was in class, I just took notes even if it was on the slide. But I guess not everyone is that way. So that's fair. That's fair, okay. Yeah, I have to delete some things, it seems, next time. Okay, 5-star. Very engaging. Yes. I love the interactive questions throughout the presentation. Kept the audience engaged and helped apply the new information. Love the case studies. Okay, so we're seeing some mixed bags with the case studies here. It was really great. Maybe some more specifics of the most common disparities you see at WIC. What can we expect as incoming DIs for WIC? Yeah, maybe I did WIC a little dirty. That sucks. I could have went more in depth into my experiences at WIC, which was a little silly. I think that I guess I didn't. I thought I did enough, but I honestly, I guess it's not enough here based on the feedback. We're seeing multiple things right now about more experience or / case studies, and too long on the slides. So I didn't expect about the case studies, but too long on the slides. Another 4-star here, very in depth. covered a lot of information across a wide range of topics. Condense the slides. 150 slides is way too much. There's definitely some info you could cut. Valid at this point. I'm seeing this is valid. Having a student's version of the slide like this first person said, I think would have been awesome. That way I can have a great class with a lot of transitions. Also condense the slide. So like the direct feedback here from this person. Okay, another 5-star here. I enjoyed the case studies and how detailed the slides were. Okay, so it seems like a very polarizing thing. If people want the detailed slides or people don't want the detailed slides, but I'm seeing more that they don't. So there's something there. 5-star, nothing really to be better. But if I had to say something small, would be maybe the volume of the slides that do not contain new info. But honestly, it was great. Okay. Another 5-star here. Really good information. Broad coverage of pediatrics. Emphasis on important information. Good use of case studies. Okay. What could be better? Maybe summary of most important things covered at the end. Dang. Okay, so actually something I wanted to do that I forgot to do or really didn't have time to do. I think a little bit of both. I forgot to do it. Was do this class in one slide type of slide and just try to like condense everything into one slide. But I didn't get to do that. I did spend a considerable bit amount of time practicing, and I think probably in that practice I just forgot. Okay, another 5-star here. I like how captivating the lecture was. W engagement. Okay, W engagement so far. I like how captivating the lecture was. It was a great balance between informational with in-class participation and also case studies. But what could be better is maybe more heavy on the case studies. I really enjoy learning about those. Okay. All right. Very thorough information. Didn't know a lot about Peds before, but I felt like I have a good foundation after this presentation. Okay. W lecture there. This is a 5-star review. And then what could be better? Maybe less slides for concentration purposes. Holy moly. Everything is about the slides, it seems. 5 stars, another 5 stars. What did you like? Very detailed and interactive. I liked having the practice questions and breaking them down. What could be better? None. Okay. A 4-star. I like the interactions and questions and simple in-class projects. What could be better? It was long but good. Maybe add some small videos. Okay, W idea maybe? Like a straight up like short form explanation of something. Small video. Maybe I could have showed like small videos of like the milestones, like what that actually looks like in person. Maybe some videos about feeding, about measuring maybe. Put in like 1-minute videos there. I think this is kind of like a maybe. This is a maybe idea. This is a very context dependent idea. I don't know. I wish they told me where the videos could be helpful. But there's something there. There might be something there. Okay, a 5-star. Very interactive and informational. Yes. What could be better? Nothing. Okay. Another 5-star. Strong focus of pediatrics. Considered this is the specialty I want to go into. And then what could be better? Nothing. Okay. Excellent, I guess. So let's do the math here. So we got, let's go to calculator. We have 18 submissions here. And we got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 5-star reviews. Oh, I guess I don't know what happened. Okay. Anyways, we know we have 18 and we got 12 5-stars. So 12 times 5, right? 60. Plus 6 times 5 is 30. This doesn't work. So 90 divided by 18. Wait, am I stupid? No, I did 5. Okay, so 4 times 6, of course. It's 24. Don't need to do that. 60 plus 24. Right? Divided by 18 submissions. Am I stupid? I think I'm stupid. I don't know how to do the math here. 12. I feel like no, this is wrong. So there's 18. But I need the score. So, well, we know that 66% of people gave 5 stars at the very least. 60 plus 24 divided by 18. Okay, what did I mess up last time? I think I messed up somewhere. I don't know what happened. This should be the score here. This looks about right. We got an average rating on the FSU Pediatric Growth and Nutrition class, an average rating of 4.67. Obligatory. That's pretty good. I'm proud of that. I think I could do better with the slides. Making a student's version sounds awesome. That's condensed, and definitely including some more of my own experiences as a dietitian, getting more in depth on the case studies. So I will say that it will prove to be difficult to do that, to give all the information and go more in depth into case studies. There's definitely a fine line balance that I need to find there as I go forward into teaching more classes and becoming a better teacher. But a W on the engagement. It seems like my strength for sure is engaging the class, being interactive, being good energy, and being a good time. So that's great. I just need to work on actually the way not the way I present the information, but the information I choose to present and how deep I go. So interactive was good, but maybe it was a bit superficial on the case studies. So maybe using that strength of interactiveness to go deeper into my own experience in a real case study. I think that's probably what I'll do for the next class. But yeah, thank you so much for watching the FSU Pediatric Growth and Nutrition class, and for also sitting with me here, reacting live to the feedback, and getting it and seeing. Look at this score, 4.67 average rating. So that's great. I'll take it. Thank you so much, and take care.